Welcome to the Medical Missions Unfiltered podcast, a branded podcast of the Jonah Inheritance, a nonprofit organization that's seeking to pave the way for a new kind of healthcare in Africa, the kind that's gospel-centric, native, and self-sustaining. We are your co-hosts. I am Ruth Coleman.
And I am Dr. Samkon Gado.
And we are excited to be here. So the purpose of this podcast is to really give you guys a behind the scenes look of our journey of what it looks like to do medical missions in our home country of Nigeria. We wanted to give you guys stories and perspectives that you may have not thought of before. So today we're going to talk about our origin. Why did we start the Jonah Inheritance? So Sam, I think one of the things I think we could start is 2018.
2018. Yeah, it's funny when, does it start in 2018 or did it start in 1991 or did it start in 1953? So, but I guess
or 1900 when our grandparents were born.
Correct.
No, I think that's a good point. I think you raise a very good point. I think one of the things the audience needs to know is that we're siblings. Mm-hmm. So I think that's helpful. And just so they know, I am the oldest. I look the smallest, but I am the oldest. Sam hates it when I say that. But I think, let's talk about where, I think it'll be good to start with our grandparents, right?
Well, we can start in 2018. I guess maybe a quick synopsis would be that we come from a long lineage of people that have ministered or are ministering to Nigeria. So our grandparents were local missionaries.
Yeah.
They lived their entire lives. They came to know the Lord at a fairly young age. And my father, or both of our grandparents actually, were heavily ministry focused. And so that was reflected, that left an indelible impression in our parents' lives, who then continued a life of ministry in and to Nigerians. And so we have grown up in a family with a heritage that has been focused on ministering and meeting the needs of Nigerians. And so for us, it has always been, that has always been preeminent. And in 2018, during my journey to become a physician, I spent some time in a hospital in Nigeria for about a month. And what I loved about that, it was longer than a short-term medical missions trip.
Yeah, I remember that.
And so it allowed me to actually begin to get a better glimpse of what the actual healthcare system looked like. And that whole time, I just could not, I remember that month, I barely got any sleep because every single day my mind was just buzzing with ways that the system could be improved. I saw a system that was broken, that was overburdened. I saw really talented physicians that had incredible skills working in very bad circumstances, and the tools at their disposal were not helpful to them. They were and they were unfortunate victims of their success. If they were good, people knew them and they saw more patients than any doctor should see. And so then the question just began brewing in my mind. What does it look like to bring a system that actually meets the needs of these physicians, not for the sake of the physicians alone, but for the sake of actually establishing a system that's meeting patients' needs?
Right.
And that's kind of the nidus of the Jonah Inheritance. And so I came back from that medical mission, from that away rotation, and I picked up the phone and I called you and I said, "Hey, Ruth, I really wish I could just find somebody who had the administrative skills to help me do this because I'm a doctor." And you're like, "You're talking to your sister who, do you know who I am?" And so that's kind of how it started.
It's funny. I remember that. I vividly remember that phone call. Mm-hmm. Like, I remember where I was sitting in my house on the table and like hearing, because I think Dad prepped me. I think Dad prepped me that you were going to be talking to me
so
about
Dad was there at the time. And so him and I had been having that conversation for the whole month.
He prepped me. And I remember just thinking at that time, like what a genius idea it was, like the vision. I think for me, I'm not a physician, and my journey has been a little bit different than yours. And so my undergraduate studies is, I have a bachelor's in Bible and I have a bachelor's in social work. And I originally wanted to go into counseling because I wanted to help people. And then I ended up going to social work because it was a very practice-based profession. And I realized, like, for me, I need to see tangible difference in people's lives. And so, but one of the things in my experience in social work with dealing with women with co-occurring mental health addictions and children that were delinquent children in the Philadelphia youth system, and then even in just working in church, was that, you have these populations that are dealing with systemic problems, and it seemed like there wasn't any difference that was being made. And I think for me, working on the front lines, I thought to myself, well, from an organizational standpoint, we've got to be doing a better job of really tackling these societal ills that we see. And so I pivoted to organizational leadership because I was like, I really need to know how, as organizations, we can do a good job from a gospel-centric perspective, because obviously our faith is really important to us. And so during this whole journey of you're going to med school and, your ENT residency, like that's the journey that I was on, of already thinking of like, I really want to make an impact for Jesus in a very tangible, measurable way. So when you called, let me backtrack. So I got my master's in organizational leadership at Eastern University, and we took a social entrepreneur class. And one of the things I loved about their program was they really focused on implementing change and developing world context. So our teacher, like one of our teachers was, he was Indian. So our case studies was how India is solving their healthcare problems, or just different things like that. So my mind was already like thinking along the lines of what you were thinking through. And I remember taking the social entrepreneurship class, and I was like, that's what I want to do, where there is some kind of sustainability component to it, but you're meeting a tangible, measurable need. And then obviously from a gospel perspective. So when you called, I was like, this is it. So it was perfect. And I think for us, I don't think you and I thought that we'd be working together like this.
So
right?
actually, I think I did.
Oh, you did?
After that conversation.
Okay.
Because that was at that time I was thinking, I had, in my mind, I was thinking like a former, CEO or somebody, and I had a man in mind.
Of course you had a man in mind. Of course you had a man.
And so then at the end of that, I was like, another thing that I think that you haven't mentioned that that made me feel like you were probably the best person for the job was, like, you had like all those like administrative, forgetting that, you master's organizational leadership, and we needed an organization, and I needed somebody to help create an organization so I could just focus on the medicine.
Right.
But when it comes to something like this, you kind of need it to be driven by a passion, and not like, oh, this is just, this is something that's really cool and I want to do it.
Yeah.
And so, you were my sister. And so you could understand that. But I think since this was medical in nature, I just remember for most of my childhood, you were always sick.
Yeah.
And and to this day, I don't even think we've really known what's made you sick. But I remember, when we first came to the United States, I remember you on the plane, sick then.
Yes.
I remember you were sick in Nigeria all the time. When we came to the United States, you were always sick. And I remember through high school, through college, you were dealing with like this still undescribed blood disorder that's been like clinically diagnosed, but no one knows what the clinical significance is. And so like knowing that you had actually had a history of accessing the medical care ad nauseum.
Oh my goodness.
Or the medical system ad nauseum. It seemed like you were like the perfect person for the job because you actually could understand the problem of access to care. So for my part, shortly after that conversation, I knew this was where we were supposed to be. And so at that point, I was still in residency, and obviously I had no time to do anything else. And so then you just like the next year or two, you just spent making phone calls
Countless
and
hours.
yeah, like
Yeah.
coming up with an organization. And so I think by the time I finished in 2020, the Jonah Inheritance was formally
Yeah. We were
was
formalized in
19,
2019.
yeah.
Yeah.
And so how we came to, and so at that point, yeah, we knew we needed to start something, but we didn't know what to call it. And so that was probably, I think, a 6-month process of coming up with a name. And
Yeah, we did come up with a name, and then we filed all the paperwork with the name, and then like 6 months later,
and then and
you
I was like,
decide you
no,
want to
I don't
change.
like it. I think we should just
Well,
go with
it was
this.
so let's talk about the name
Yes,
because it's a very unique name.
it is. It's
and
weird, and people still don't get it
they
right.
still don't get it right. So
It's the Jonah Inheritance.
yes,
It's not Jonah's Inheritance.
it's not the Jonah Project.
It's not the Jonah Project. It's the Jonah Inheritance.
It's not Jonah.
It's not the Joshua Tree Project. No, I'm sorry.
But I love our name though. So I think let's talk about how we came up with the name,
Sure.
the Jonah Inheritance.
Okay.
So you want to go?
Well, so for me, so we known that it needed to have like a legacy component to it.
Yeah, most definitely.
And in light of we wanted to honor our mother and father, and so I remember going through as I was reading the Bible, I came across a passage. I knew that I wanted the ethos to live in and to sound and to exude the spirit of Jesus Christ. Because whether or not you accept that he is the Son of God, whether or not you accept him to be who Christians claim him to be, you can't deny that this person 2,000 years ago had an ethos that still reverberates to this day. So I knew that, and when you think of meeting the needs of the poor, which is our focus, it's the poor and the disenfranchised. You think of Jesus, Mahatma Gandhi, Martin Luther King, those people. Anybody that's that he has been the template that those people have used. So with that said, I was just reading some of the things that he said about himself, and we are a Christian entity, and our goal is to actually show people who Jesus is through what we're doing. And whether you believe this to be true or not, but in the Bible, Jesus Christ is going around and he's performing all kinds of miracles. He's healing people's bodies. He's touching them. But when they ask him to do that, Jesus is saying, hey, that's not the most important thing.
Yeah.
And he references this vague story he references Jonah. And it gets a little esoteric, but the idea is what made Jonah's story meaningful is the fact that all Jonah had to do was just deliver a message.
Yeah.
And that message was enough to turn the hearts of an entire city. Jonah didn't perform any miracles. He didn't do anything. He just delivered a message. And so Jesus was saying that what people need is a message of the gospel. People don't need, the people's greatest needs aren't that their bodies are fixed. That's important because he did that. But the most important message is that they understand who Jesus is and what Jesus came to do for them. And so I wanted that to be the ethos. So Jesus Christ calls himself someone greater than Jonah, or he calls himself another iteration of Jonah. Right. So I knew at that moment that, okay, I like this. But then when you couple, and I'll let you speak to this, but our parents, then it just seemed like the perfect name.
Yeah. So the Jonah Inheritance is the literal translation of our paternal and maternal family name. So Gado's our paternal family name, means inheritance.
Inheritance.
And then Unana is our maternal family name, and it means
Jonah.
So I think for us, one of the things about the Nigerian culture that it's very communal and it's very familial. So
and generational.
Generational. We don't see ourselves as individuals. We see ourselves as part of our family lineage. And so that's really important. And I think for us, we are very aware that we are where we are is because of the faithfulness of our grandparents and of our parents.
Correct.
And so this was a way of honoring our grandparents. So in our language, your grandfather, you call them Shiji, and then your grandmother's called Kaka. So for Kaka and Shiji, for us, it was like, how do we honor these individuals that sacrificed their lives that most of the world will never
We'll
know,
never know.
will never
Yes,
know
we'll
of.
never know.
But it was a way of saying we want to carry this legacy of them stepping out in faith, preaching the gospel, but then also being very aware of how to meet the tangible needs of people. I think when you think of the work that we do, I think in scripture, so many times we separate the secular and the sacred, right? But Christ says in everything that we do it for his glory. And so there is no separation in it. And so they always lived that out. So for us, we said, well, how can we really honor them? And so the Jonah Inheritance was how we were able to do that. And I love that.
Yeah.
I feel like they're looking down on us from heaven, and hopefully that they're proud of the work that we're doing. But yeah, that's where we got the name from. And the goal is, we want to, we're seeking to pave a way for this new kind of healthcare in Africa, the kind that's gospel-centric, native, and self-sustaining. And I just think of the facilities and the work that we do and their name is going to be, on the buildings. And it's just a homage to them. And I think also Nigeria is a very diverse country. It has over 250 ethnic groups and over 500 languages. And our tribe is like, I don't even know if you can find it on the map. Can you find it?
It's pretty obscure, actually. I've only seen one map that actually had it. It's actually in the clinic in Bingham University Teaching Hospital.
Really?
And there's a small little dot that says Tangale, and I was like, well, that's me.
Right, because most Nigerians that you meet are either Yoruba or Igbo.
I've met very few people who are from our part of the country.
Yeah, so Nigeria has 3 major tribes. And so you kind of identify based on where that tribe is.
Yeah.
So most Nigerians usually fall in Yoruba, Igbo.
Yeah.
And we're not that. We're from north central Nigeria, I think is where it is.
Yeah. So I guess it's probably good to explain this a little bit. So if you have 250 different ethnic tribes and over 500 languages, you got to have some way to actually communicate. And so most tribes have their own language, but then within the tribes that are next to each other, there are 3 main bigger tribes or 3 trade languages, and that's Hausa, Igbo, or Yoruba. And then even if you extrapolate that even further, the national language is English because all those need some common language. And so
we were colonized by the British.
Correct, which is why. So like, for instance, our parents speak English and they speak the trade language, which is Hausa, which you speak better. I kind of speak, but I can understand. And then they also speak our tribal language, which is Tangale. And that our parents, it's not my fault that I never learned because
it's completely their fault that we've never learned. It's completely their fault.
Anyways, so that is usually and we don't see most people. Our experience has been that there are not too many people from the Hausa subsect that are actually here in the United States, and that's usually northern. And there,
which is predominantly Muslim.
As
well.
And there are many reasons for that.
Yeah. So we've talked about the name. We talked about 2018, which was the genesis of this iteration of, I would say, ministry work for a family. So let's talk about the methodology. So you spent a month, at Bingham University Teaching Hospital and kind of seeing the current state of the Nigerian healthcare system. And so what were some of the thought process of how are we going to really tackle this problem of healthcare in Nigeria? Because Nigeria is what? The 4th worst in the world? Yes,
it's probably gotten worse, but in the last we checked, it was the 4th worst based off of World Health Organization. At this point, it doesn't even really matter.
But probably all the same.
Yeah, I would say So really the methodology, it took many years and it's still kind of being formed. But what we have basically, we feel like we have a framework that is actionable and it's informed by the data and not just research, and there are people that are actually employing certain aspects of this. So at the end of it first started as a surgeon. I thought to myself, what we need to do is we need to be able to provide surgical services. And so that was our initial intent. We were thinking we'll start with an ambulatory surgery center. But then we realized that the problem with starting with surgical services, even though that's very, very needed, and that was really born out of the Lancet Commission on Global Surgery that said that we needed a whole lot more surgeries, or the developing world is the medical infrastructure suffers from not having adequate surgical access. And that's obviously difficult because surgeries require equipment, they require another degree of training or medical training, and it requires a pretty significant infrastructure. But the Lancet Commission on Global Surgery was essentially saying, what's the best way to go about elevating this or solving this problem in the developing context? And so we were thinking along those lines. And so we started developing a plan for an ambulatory surgery center, which is still part of our goal. But we realized that there would be we would be reliant on a broken healthcare system
to feed it.
We would be relying on a system that was not capable of, or that could not consistently diagnose, could not consistently prevent, and there would be no means to follow these patients postoperatively.
Yeah.
So then we realized, okay, well, if we're going to do that, we need to be able to control who we're feeding into this. Right. And this goes to show that in any healthcare system, if it's going to be actionable, if it's going to be healthy, it has to have a very strong core of primary care. And so then we kind of circled back and we said, okay, we need to start with primary care. But then when we started looking at why the system was broken, we started realizing that the reason why the system was broken was that just there was not enough people to actually deliver this product we call healthcare. And there was no one to deliver the product because doctors were leaving. One of the most amazing finds that we were able to discover in our research was that Nigeria was actually producing them. They just weren't keeping them.
Which is mind blowing.
Yes, it is. Yeah, and I like playing this little game with most of our donors. I would say just to show you how many doctors Nigeria actually produces and does not keep, just go to your local hospital and just look. Yeah,
you will find
just
them.
Look. You'll find a doctor with a Nigerian name there, and of course, it may require a little bit of skill for you to know what a Nigerian name looks like. We know what those look like.
Yeah.
And so we started thinking about that, and we said, okay, well, so we need to backtrack a little bit. We think ambulatory surgery is very important. And there's a reason we when we say ambulatory surgery, it means outpatient surgery where you don't have to come into the hospital and stay. So once that actually began to flesh itself out, we thought, okay, the focus is going to be primary care. And there's this need for physicians. Physicians are leaving. Why are they leaving? And so then we started thinking to ourselves, the reasons they're leaving: low, irregular salaries, bad resources, and they just don't have the infrastructure that's stable and supportive enough for them, so they're going somewhere else. And so in order for a healthcare system to work, there has to be people to actually provide the care, and there has to be a way for people to actually afford the care that's not free. There has to be an exchange because healthcare is a resource. But there is a way that, in many ways, it's a good thing to give healthcare to people, and you want to be able to give it away easily and, if possible, for free. But at the same token, you want to be able to make sure that resources are being covered, and a doctor is being rewarded for their time. And so at that point, we decided, okay, we want to come up with a system that rewards people that stay. And looking at the strength of the dollar, at the time, it was about $1 was equal to, let's say, I think it was about 400, 500 Nigerian naira.
Wow.
So to give you perspective, the top doctors in Nigeria that are working in the national hospital are making about 12 million naira a year. And at the time, that was about $36,000. a year. Imagine paying a doctor $36,000. And so that number has actually gone down now because the dollar is actually stronger. And so the economics actually work favorably. And now paying a top doctor in Nigeria is closer to $15,000 to $20,000 a year.
That's just nuts.
Yeah. So we thought, well, most of the doctors that we're dealing with are not making anywhere close to this.
Yeah.
So what would it look like to be able to find and vet a really strong, solid doctor who's proven himself, who has the time horizon to be able to be part of a system for a very long time? And I think we can come up with doctors who, for the leveraging the dollar and the naira, we could do that. But then that was one end. That was one end of the algorithm. The other end was just, well, then how can people afford this?
Right. And the misconception is that people in developing countries like Nigeria can't, don't want to pay for medical services, and that's not the case. Because I came across this article that was just talking about, the state of the Nigerian healthcare system, and it said that Nigerians spend about $1 billion. Actually, it's 1.2 billion to 1.6 billion dollars a year in medical tourism. So they're leaving the country, going to Israel, like the current Nigerian president, and UK and India for medical services. So you have a population that does have the economic resources to pay for it.
Sure, yeah. This is going to sound really more like a speech, but Nigeria is the largest economy in Africa. Just when you have 206 million people, I think it's easy to get that number. But additionally, it's the 27th largest economy in the world. So it's not that people aren't, that the money is not there, and there are many reasons why. So that you can talk about the distribution of the wealth and how that is. I mean, America has its own issues there, but really, the question is not that most people. I think 87 to 90% of people in Nigeria pay out of pocket for medical expenses. So people are willing to pay. The problem is the price point is just too high.
Right.
And so one of the things that I realized when I was at Bingham University was I looked at how much they were charging for surgical services. And while I was there, the whole month I was there, I worked almost every single day, and I only performed about 8 or 9 surgeries. And that's because only about 8 or 9 people could afford those surgeries.
That's crazy.
And so then I looked at their.
And how many do you do in the States, like in your practice right now?
8 or 9 in a day. So depending on which surgery, it could be 8 or 9 in a half day. But I looked at their charges and I said, what would happen if you just sliced those charges in half and just took a loss? How many people could actually afford it? And so I did the math and I thought, well, if you just take these charges and just slice them in half, you may not be making as much per surgery, but you may have more people who are actually able to afford the surgery. And at the end of the day, you could actually turn a profit.
Right.
So I just took a normal day at St. Louis University Hospital, and I took the same surgeries that we would be performing, and I cut the price point in half, and what would be the equivalent. And if you could get that equivalent volume, you would make enough in a day to pay a doctor for a month. So I thought to myself, so I wonder if there's a better business model here. And this was really just borrowed from Aravine Eye Hospital in India, who has actually developed this amazing, robust system that's actually self-sustaining by 70% of their cases are for free, or given for free or nearly for free. Only 30% of their patients are actually paying the at-cost price, but because they do so much volume, they're actually able to turn a profit.
Right. And that's something you can do with surgical services, right?
That's something you can do with surgical services. And so that idea was, well, we know that people cannot afford as much. So if we're able to keep our overhead down and we're able to have a lot of people coming through, then there may be a way that we can actually be sustainable. And so there are other things that go into that, like insurance schemes that get a little bit more complex. But our thought was just, we have a way we can meet the need from the supply perspective, and I think we can help meet the need from a demand perspective as well. And thus, our methodology was formed.
Yeah. And I think that's really important because when I read the Lancet Commission on Global Surgery, read the report, and then that led me into other studies that they had done. And there was a paper that was actually talking about, how do you address some of the healthcare issues in sub-Saharan Africa? And there were several physicians that had written this paper that were Nigerian, and they said that, the way forward really is creative solutions, creative in-country solutions that address these issues. And I think it reinforces what you just talked about, where we have to really start looking at these problems from a very different perspective. Because traditionally, from a governmental standpoint, it's either been poorly executed or poorly run. And then, from an NGO perspective, nonprofit perspective, you usually have these medical missions like flyovers, short-term fixes that are really not investing in the local infrastructure and really investing in the people that are doing the work, because they're the ones best positioned to actually address these issues.
Correct,
and so I think what I loved about and still love about our methodology, and when we were talking about and fleshing it out, is that really we are looking at we're merging these two worlds of saying, from a business standpoint, we really need to understand the numbers, we need to understand the market, and we need to understand how we can provide care that's affordable. But then at the same time, we need to be able to meet the social problem in a way that has a lasting impact.
Sure.
And that there's deep change, and we're actually moving, the next evolution of how we're tackling these problems just has to look different. And so I think we've really, through our own research and discussions, have really been able to kind of flesh that out. And that's how we kind of arrived at, these three pillars, that our approach really is a model, right? We are trying to invest in infrastructure that's able to provide care for generations to come. And so it's like, well, what does that look like? Obviously it has to be gospel-centric, because our faith is really important to us. And I think for you and I, in our own sectors, we kind of came to this disillusioned perspective where it's like, you have to acknowledge the spiritual condition of people. Otherwise, we're not really addressing their holistic health. And then Native, we have to tap into this resource that Nigeria has more than enough people. Not only do we have more than enough people, meaning from a demand perspective, but then we also have more than enough physicians that are capable, and we train them. So the need is already there. And then self-sustaining, where it's saying our approach has to be reproducible, and we have to start really thinking about the long game, and that in everything that we do, you're filtering it through a sustainable lens. And I think our approach with the Jonah Inheritance is that's the lane that we're going through. It's surgical. Our end goal is to really tackle the surgical crisis, where 5 billion people around the world do not have access to surgical care. And 81 million people are delved further into poverty because of the financial cost of surgical care. And 30% of the world's disease burden is managed by surgical care. And so you have this quiet epidemic that nobody's aware of. You hear about malaria, you hear about HIV, you hear about tuberculosis, of what the Gates Foundation and trying to eradicate tuberculosis. But at the same time, there's people have other conditions, and you need a healthcare infrastructure that will meet people's needs.
Correct. Yeah. It's the analogy that I think of is just like there are so many, a healthcare a healthy system has to have so many integral roles, and the dealings with the primary care, that's your lineman. That's your bread and butter. That's the base. That's the foundation. But you need a good quarterback. You need a good running back.
Yeah.
I think the most important position on the field is the running back, but
yes,
that's neither here nor there. Actually, I don't. But and I think those would be the surgical services. Those are things that only work in the setting of a strong, healthy primary care system. But you need someone other than linemen moving the ball, and I think so. It's our vision.
Yeah. So I think this is a good place to kind of end. I think what we wanted to do is just really invite you guys into the conversations that Sam and I have every day with regard to the Jonah Inheritance and the work that we're doing. And clearly our hope is that you've seen that we're really thinking through all these components to make sure that we're doing our due diligence and that we're really being a part of the solution and not a part of the problem. So thank you guys for being here. We have 11 more episodes, and our goal really with the next upcoming episodes is to give you guys a behind the scenes look. We're going to be inviting experts who will be talking about our model. We're going to talk about what does it look like to have a gospel-centric approach? What does it look like to have a native-led approach? What does it look like to have a self-sustaining approach? And so these individuals are going to come and we'll just talk through. We'll talk more about the medical mission trips that we've been on, and where we're ultimately going, because our vision is to equip African doctors to build sustainable healthcare networks, to improve healthcare access by equipping African doctors to build sustainable healthcare works. So thank you so much for being here with us today. So how you feel, Sam?
I feel good.
You feel good? We did good?
Yeah.
So thank you guys for coming, and we'll see you guys on the next episode.
Absolutely.